Hello all, I am Dr Hirennappa B Udnur, pulmonologist practicing at Bangalore at Inspire Specialty Clinic, Manipal Hospital and Baptist Hospital. First of all, at the outset, I would like to thank CCI team, webinar team, who are doing a great job in marathon webinar sessions. I have been seeing them lockdowns and they are really good. And the way they keep up their time is so good. And I would like to thank Dr. Krishna, NH, Dr. Pradeep Narayana, Dr. Vijay, Dr. Ravi Dosi, and Dr. Narendra for giving an opportunity to moderate one of CCI session. And today's topic will be interesting one. Before proceeding, our condolences to Dr. Krishna, NH, and family as he lost his father-in-law recently. Moving forward, our topic of interest today is arrhythmia in a critically ill pulmonology patients. As we all know, in pulmonology, we have a lot of things which are common for heart and lungs. And especially the ECG becomes most important tool in solving our simple problems. And sometimes we have to work together with cardiologists and to find out what exactly is the situation. And one of the instances which happened 2-3 days back, I will tell you, and a young patient in a postpartum lady came with unexplained hypotension, and she is incidentally detected to be COVID positive, and she is on noradrenaline infusion. Her echo came normal, and cardiac the CT scan came normal, and her ECG showed junctional rhythm. We are not able to explain that, and since COVID came positive, we sent Tropi, COVID viral myocarditis. We started higher antibiotic. We sent procalcitonin, antibiotics and antiviral. She improved, and there was a hypokalemia, and we gave steroids, and this hypokalemia was corrected. Slowly, the junctional rhythm improved to a sinus bradycardia, and she is doing well. These are simple little problems. If you can do a simple ECG, which is cost effective, and if you know it well, and some cases, as we move on this over a period of time, we'll be concentrating more of lung, CT scans, or bronchoscopies, and all. I know some are practicing as critical care specialists, and they are well versed with this thing. And slowly we are evolving where a patient's responsibility is a team responsibility. We treat the patient as a team. The individual management of the patients, apart from OPD, in the inpatients, it's always team and for the better outcomes. And this arrhythmias, as a one scenario, there are umpteen number of examples for this rhythm disturbances which causes, especially in COPDs, we get lots of sinus tachycardia as a commonest form, and we see arrhythmias and atrial fibrillations. We have a lot of issues with anticoagulants, sometimes rheumatic heart diseases. What are the things to be used? And all those things, you have burning questions. We need to sometimes make a shared decision making in treating the patients. And today's panel is all about those things. And we have a esteemed panelist in our panel today in discussions. And I would like to welcome these panelists. And the first and foremost, we have Dr. Chandra Mouli from Kakinada. He is a renowned cardiologist practicing at Kakinada. Is electrophysiology. Electrophysiology is a subject after DM, after doing a DM cardiology, and they are specialized in rhythm disturbances. And I know for sure they have some certain special procedures with them, like radio frequency ablations. They are very specialist in rhythms and rhythm disturbances, and they are above cardiologists. And welcome, Sir Dr. Chandra Mouli. And we have another doctor in our panel, and he is a pulmonologist who is practicing at Batra hospitals. And we know they are practicing. There is a overlapping between critical care and pulmonology. And I would like to welcome him also on the panel, who exactly know what is the pulmonologist perspective in reading the ECG. And this session is for all of pulmonologists, all those pulmonologists and other practitioners where small little issues like ECG issues and all, we tend to neglect it, we tend to relearn, unlearn, and definitely we are going to become better and better as we practice day in and day out, and every day is a learning for us. And the next in the panel is Dr. Nilanjan, who is from Astronomedicity, and I would like to welcome him also on the panel. And let's start this panel as a discussion on arrhythmias for through the eyes of pulmonologist perspective, and and let's hear from the specialist so that it helps in our practice regularly. And if you are aware of certain things, it prevents a lot of other problems, especially if you are working in a multi-speciality setting. We need to have a holding hand. There should be some hand holding from these doctors, and then our outcomes of our patients will be really good. Thank you. Let's start our session. Thank you.
Thank you, Dr. Hirennappa, for the kind introduction. And thank you, CCI, for this invitation. And I feel very happy at this moment. I feel very happy to come out here to share my knowledge, some of the ideas that I have regarding the ECG with all of you guys. And specifically, I would like to thank Dr. Vijay, who is a good friend of mine, for giving me this opportunity to come here and share some few ideas regarding the ECG. Before proceeding further, this is the hospital where I work. This is the trust hospital based in Kakinada, which is a city in the coastal area of Andhra Pradesh. And these two are my colleagues, Dr. Nishant and Dr. Pavan, without whose support I couldn't see. Their support is immense, and I feel very proud to have them as my colleagues. So before proceeding further, first of all, I'd like to tell about this ECG, because this is the ECG. Probably, I can say that this ECG has drawn me towards cardiology and away from pulmonology, because this is the ECG I got in my critical care exam, in my final critical care exam. So in the exam itself, I got so many doubts after seeing this ECG. What to say regarding the ECG, like whether it is a sinus tachycardia, atrial flutter, because as a pulmonologist or a critical care specialist, I didn't have much idea regarding the ECGs. Even names also, I was not aware. I didn't know at that time. So I got very confused. Fortunately, I passed the exam. I cleared the exam. So after that, I started regarding the ECG. I started knowing few things about ECG. Probably that might have helped me to clear the cardiology exam and also the electrophysiology fellowship also. So to start with, in this half an hour talk, what I would like to touch is, I'd like to touch regarding few basics regarding the ECG, like that are important for analyzing the ECG, and what are the changes, we can expect in a patient with a pulmonary disorder, and what are the arrhythmias we can expect in patients and such patients. So to start with, first of all, this is the normal conduction system of the heart. Like the way the heart has its own blood supply, it's blood supply. So it has a conduction system. So because of this, the heart continuously contracts till we die. So this is and you all know regarding this conduction system. It starts with the SA node, conducts to the AV node, and AV node down the AV node, it conducts to the bundle of his. Again, the bundle of his, it divides into two, like a right bundle and a left bundle, whereas the left bundle divides into anterior fascicle, posterior fascicle, but the right bundle continues down as a single unit. And this is the way the conduction system is spread across our heart. So starting from the atria to the ventricle. And how does the conduction pattern spreads in the in our heart? So once the SA node, it conducts through particular channels to the AV node. And once that it reaches the AV node, it conducts down to the bundle of hairs. And from the bundle of hairs, what happens is it conducts further down, and it is the left bundle that is activated first. It's so the initial, it is the left side of the septum that is activated first. This is the reason for getting a Q waves in the right-sided leads, the left-sided leads, or a small R in the right-sided leads. So after the left side of the septum is activated, the wave activation of wave moves towards the right, and then the activation pattern continues along the bundles, like the left bundle, which activates the left ventricle, and the right bundle, which activates the right ventricle. So this is the normal pattern of activation. Whenever there is any abnormality, like whenever there is any block, like a bundle branch block or a fascicular block, whatever may be, the pattern of activation changes. So what happens is the conduction system has got two properties, like the velocity of conduction is rapid when compared to the surrounding myocardium. So whenever there is a normal conduction, the wavefront spreads very fast in the conduction system. But whenever there is a block, instead of the conduction system, it uses the surrounding myocardium for the conduction to take place. So what happens is, for example, if there is a right bundle branch block, what happens is the impulse goes down through the left bundle. It activates the myocardium of left bundle first, and then through a transmyocardial spread, it activates the right ventricle. So there is a long delay. In this type of conduction, the conduction occurs rather slowly. So this is the reason for the wide complex we see in case of a bundle branch block. And the same thing applies even in VTs, ventricular tachycardia, because it's a myocardial spread rather than a conduction system conduction. So this is the brief introduction regarding the normal activation pattern of the ventricle. And here I would like to just emphasize on 2 points. I think you all know regarding this, but just a recap of what we know. See, in an ECG, basically what we see in an ECG, the deflections we see is a resultant vector of many scalars. So that scalars have different directions and different properties, different ways of conduction. But the resultant deflection, what we see in an ECG, is the ultimate vector. That means the vector travels in the predominant direction of electrical axis. So keeping this in mind, so if you consider these 3 pins as the pearls we have, so any wavefront that moves towards that gives a positive deflection, and any wavefront that is moving away from that gives a negative deflection. So you all know that. And one more thing I would like to add here is any wavefront which is traveling perpendicular to that gives a equiphasic one, and which is traveling parallel to the lead gives a positive deflection. So the more parallel, the more positive will be the deflection, and the perpendicular gives an equiphasic or predominantly positive or a predominant left, depending on further deviation from the lead. It gives a equiphasic QRS complex. So this is one basic. And the second basic I would like to touch here is the position of leads. So whenever you are seeing the heart, imagine the heart is in the center of the chest. So, but with a slight orientation towards the left. And what are all the leads which we need to see? Like, what are the different leads we can see to infer particular things? Like, if you look at 1 and AVL, these are the lateral most leads. So if you are looking at the lateral wall of the heart, so 1 and AVL gives good information. And if you want to see the inferior wall of the heart, inferior side of the heart, so you need to look at 2, 3 AVF. And the other things are the only leads that is towards the right side of the heart is V1 or an augmented AVR. So these are the only 2 leads where the leads are on the right side of the heart. The rest of the leads are on the left side of the heart. So, combining these 2, so if any wavefront is traveling towards 1 and AVL, like it needs to travel from the septum towards the lateral wall. right? So if it is traveling from the septum to the lateral wall, so 1 and AVL will have a positive deflection. That means there will be an R complex. If at all the impulse is traveling from the lateral wall towards the midline, like towards the septum, sometimes it happens in VT or any pathway. So in those scenarios, what we will see is a negative deflection, like S in 1 and AVF. So similarly, 2-3 AVF also. 2-3 AVF are the leads that look at the inferior border of inferior side of the heart. We can sometimes there can be we can call it posterior, we can call it inferior, whatever. But if you are looking at these 3 leads, 2-3 AVF, basically that means we are looking at the inferior side of the heart. So any impulse arising from the inferior surface will throw a what you call a negative deflection. So any impulse that is that is arising from the anterior side, from the above, like, and coming towards 2-3 AVF will throw a positive. And based on this, we can call it a superior axis or an inferior axis. If at all 2-3 AVF has a negative complex, it is superior axis. That means the impulse is originating from above and coming below. So it is originating superiorly and coming inferiorly. Whereas when the inferior leads have a negative complex, that means the impulse is originating inferiorly and going upwards. So that is the one. And V1. See, look at the V1 is a very important lead which gives good information. Likewise, similarly, AVR also is the one, because these two are the leads that are located on the right side of the heart. So take, for example, ventricular tachycardia. Ventricular tachycardia, predominantly it arises from the left side of the heart. If you take LV is involved, so what happens is the impulse, the predominant vector of ventricular tachycardia that originates in the LV travels towards the V1. So that means it will be a positive complex in V1. Whereas when it is moving away from, normally what happens is the impulse predominant vector moves away from the V1. That means it gives a negative complex in V1. So likewise, knowing the V1 and AVR are important. And these are the few things we need to keep in mind before analyzing any ECG. And the other thing is, because majority of the heart mass is an LV, so the electrical axis or the vector, predominantly we speak regarding the LV rather than RV. And if you look at the V1 to V6 are the chest leads, some leads are at the base, like, and some leads are at the apex. Like if you look at V5, V6, predominantly they are at the apex. So anything that has a negative complex in V5, V6, that means the impulse is originating at the apex and it is traveling towards the base. So these are the few things we need to consider. So the next important thing that we need to consider is the axis determination of the heart. So if you look at the heart, basically it is not the rotation of the heart or the position of the heart in the system, in the chest. Basically, it is the electrical axis of the heart. That means the electrical axis of the heart has a slight leftward orientation, and the normal axis ranges between +60 to -30. Generally, we call it a normal axis. So it can be anywhere between +60 to -30. If at all any deviation is there from -90, like if the axis is around 110, 100 or 120, we call it a right axis deviation. Or if at all anything is there, like if at all the axis is -45, -60, -90, we call it a left axis deviation. And the other terminologies here is a clockwise rotation or an anti-clockwise rotation, counterclockwise rotation. Clockwise rotation, most probably we see in pulmonary patients, like there is a clockwise, the RVH, whatever it may be, the heart slightly rotates clockwise. So there will be a right axis deviation. Whereas in some other conditions where there is an LVH or some fascicular blocks, there will be a slight electrical clockwise rotation of the heart. Not as such the heart rotates, but it is the electrical axis deviation. So these are the few causes for left axis deviation and the right axis deviation. And how do we determine axis? So there are many, but the simple way, look at two leads, one and AVF. So look at complexes are like if both one and AVF have a positive complex, it's a normal axis. If one is positive and AVF is negative, then it is a left axis deviation. Whereas when one is negative and AVF is positive, it's a right axis deviation. And if both are negative, we say that it is a northwest deviation. It's an extreme axis deviation. That means it can be extreme left axis deviation or an extreme right axis deviation. So this is the simple way of determining the axis of the heart. And why determination of the axis is important is because to know the rotation of the heart, and also sometimes we can know the pattern of electrical activation. Like in case of fascicular blocks in the anterior fascicular or a posterior fascicular block, we know the electrical, like a patient with the anterior fascicular block, hemiblock, we call it a hemiblock. So there will be left-sided left axis deviation. The other way around, like a posterior fascicular block have a right axis deviation. So this is the general thing. Any deviation from this, then we need to consider the other things also. So in this way, the determination of axis is also important. So coming to the changes in patients with the pulmonary problem, like a lung pathology, what happens is any lung patient, like a patient with a COPD or a pulmonary embolism or whatever the lung condition, ILD. So what happens is, so the pressures or the effects of this lung condition are directly reflected onto the right side of the heart. So the RV and RA and RV are the chambers that bear the brunt of that pulmonary pathology. So everything is reflected in this. And how is it reflected means, say, take for example pulmonary embolism. So just to tell you what happens is in a pulmonary embolism, the embolus travels and sits somewhere in the pulmonary artery, obstructs the pulmonary flow in the pulmonary artery. That means there is a rise in the pulmonary artery systolic pressure, which is reflected again into the RV. So RV has to pump against that resistance because it needs to overcome the resistance and moves the blood in the forward direction. It needs to pump against this resistance. That means there is an increase in the right ventricular systolic pressure also. In meanwhile, what happens is the pulmonary valve, which is a valve between the RV and the pulmonary artery, it gives away. If the pressure is too much, it gives away and start regurgitating. So we can see a pulmonary regurgitation also. So these are the acute changes. And on a chronic thing, what happens is this RV, so whenever it is contracting against an increased resistance and an increased pressure, so the chambers generally hypertrophy, the muscles hypertrophy. So what we can see is an RVH, right ventricular hypertrophy. And with this, what happens is the right ventricular end diastolic pressure increases. So with the increase in right ventricular systolic pressure and the right ventricular end diastolic pressure, this will be reflected into the RA. So there will be tricuspid regurgitation because of the RVEDP, increase in the RVEDP, which is reflected again in the RA, right ventricle, right atrium, which generally there will be an enlargement of the right atrium. We call it a right atrial enlargement rather than right atrial hypertrophy. So these are the few changes what we can see in a patient with a pulmonary problem. And these are the changes that are reflected in the ECG also. So if you look at the criteria, how to identify RVH or RA in the ECG is, so there are many criteria, but remember few points, predominantly R in V1. So R in V1 and S in V5, V6 and a right axis deviation. So these 3 points are important to say that the patient has a right ventricular hypertrophy. Of course, there are many criteria and there are many things where we can say judge the amount of hypertrophy, the amount of pressure overload on the heart. So, but the 3 important things we need to look at in the ECG to say that the patient has a right ventricular hypertrophy is predominant R in V1, S in V5, V6, and a right axis deviation. So this is the normal presentation, and and this R and V1 can be of many morphologies. Like it can be a QR, it can be an RSR pattern. So RSR pattern, or it can be simple R, maybe RS, predominant R by small s. So there are many variations in the presentation of this R in V1, but whatever it may be, if the R wave in V1 is large enough, if it is more than 0.7 millivolts, then we can say there is a right ventricular hypertrophy. So the next thing is, the other things we need to see is whether there is any atrial enlargement. And there are few criteria that are proposed to look at, because if you look at the right atrial abnormality, like right atrial enlargement, how can you say that? We can say by looking at the lead 2. If you see a peaked P waves, what we call it a P pulmonary generally, if the voltage of P wave in lead 2 is more than 0.25 millivolts, then we say it's a P pulmonary, and it is a direct indicator that there is a right atrial enlargement. And also the other criteria we look at is prominent initial positivity in lead V1 or V2. If it is more than 0.15 millivolts, then also we can say that. And there are some other criteria like radii under the curve, all these things. Of course, if you know the first two, that is enough. If you know the first two, that's enough, and we can make out whether there is any right atrial enlargement or not. And we need to know about the left atrial abnormalities also, because sometimes the right atrial pathology or the right ventricular pathology may not be entirely because of the pulmonary problem. It may be sometimes related to the left ventricular or left atrial enlargement also. So we need to look at it. We need to know regarding the left atrial. How to make out? If the P wave duration in lead 2 is more than 120 milliseconds, or the prominent notching of P waves, particularly in lead 2 with an interval between the notches of more than 0.4 milliseconds, then we can say that there is a left atrial enlargement. So these are the various patterns to identify that we see in the ECG, and these help in identifying right atrial enlargement or a left atrial enlargement. So if at all patient has both right atrial enlargement and left atrial enlargement, these are the normal presentations. We see, particularly for a P wave morphology, we look at lead 2 and V1. So if the lead 2 has a hump, double hump with a notch in between, and the distance between the two notches is more than 0.4 milliseconds, so then we can say that it is a biatrial enlargement. And also, if you look at V1, it is a biphasic, which is predominant positive, and also a negative wave in V1, then we can say there is a biatrial enlargement. These are the patterns we see. And the other things, after the chamber enlargement, what are the other things we can expect is bundle branch blocks. Because whenever there is a pressure overload or a volume overload, what happens is the myocardium of the right ventricle stretches, and there is some underlying ischemia also. So because of the stretch or the pressure, maybe some subendocardial ischemia will be there, causing some ischemia to the underlying conduction system, like bundle branch. So whatever may be the reason, there we can see a bundle branch block, particularly in patients with pulmonary problem, particularly a right bundle branch block. So how to identify? What happens in a right bundle branch block is, I already told it. So initially the left-sided septum is activated, and from there, if there is a block on the right bundle branch, the impulse goes along the left bundle, and it activates the left ventricle completely. And from there, the impulse travels transmyocardially. That means instead of the conduction system, it uses the septum and it conducts transmyocardially and activates the right ventricle. So this is the reason for seeing an RSR pattern in V1. Like the initial small R is the first initial deflection, like left side of the septum. And the next S is because the impulse goes along the left bundle, it gives a negative deflection. And then the predominant vector is a transmyocardial spread that occurs towards the right side. It gives a large R. So that is the reason for RSR pattern in a right bundle branch block. And what are the other criteria is, because QRS duration is more than 120 milliseconds, A broad notched secondary arvus, particularly in right precordial leads, wide deep S-Vs in left precordial. Because the opposite thing, V1 is the one that looks at from the right side, whereas the opposite leads are the V5, V6. So whatever changes we see in V1, V5, V6, we see just the exact opposite of the change, the opposite changes in V5, V6. And delayed intrinsicoid deflections in the right precordial. So these are the few criteria by which we can say that the patient has a complete RBBB. When we call it as a complete RBBB, if the QRS duration is more than 120, we call it 120 complete. If at all this criteria are there, except for that QRS duration is less than 120. If it is more than 100 and less than 120, we call it an incomplete RBBB. We can also call it a IVCD, intraventricular conduction delay. So this I think I have already discussed. And these are the various patterns of R complex, particularly we see in RBBB. And coming to little bit regarding the LBBB, so the opposite thing happens. What happens in LBBB is the initial left side of the septum is not activated because there is a block there. So it is the right side of the septum that is activated. This results in the loss of Q in V5, V6. So after that, so the impulse travels directly down the right bundle and activates the right ventricle, and through a transmyocardial spread, it activates the left ventricle. So this is the pattern of activation we see. And what are the criteria for left bundle branch block? Defining the left bundle branch block is QRS duration more than 120 milliseconds, and QS or RS in V1, like it's a predominant negative complex in V1. And the left-sided leads, monophasic slurred or notched RVs in V5, V6 are 1 and AVM. And the other thing is absent septal Q waves in left precordial leads. So that is important because the initial part of the activation occurs on the right side. We don't see the normal septal Q waves in V5, V6, particularly in patients with an LBBB. That we call it a true LBBB. So with this keeping in mind, so if you come to the pathology, different pathology, pulmonary pathologists, like a patient with a COPD, emphysema, or pulmonary embolism, what are the changes we can see in ECG is patient with a COPD can have like right atrial enlargement, right ventricular hypertrophy, and generally it is and many patterns defining the right ventricular hypertrophy. So all these changes can be there, but before considering these things, three things we need to consider here. Like there are some confounding factors. Like every patient with the COPD doesn't have everything. Like doesn't have every feature of RVH or doesn't have every feature of right bundle branch block. This is because of the confounding factors. Like if the patient has a severe right ventricular airway obstruction or emphysema, or if the afterload on the airway is so much, these changes generally modifies. So they can be there can be a pure presentation of RVH with an right atrial enlargement with signs of RV overload, pressure overload, and also mixed changes. Like there can be in between changes also. Like the RVH may not be represented properly with all the criteria, or RBBB may not be established completely. So these things we need to consider. But some changes we need to consider is patient will have right axis deviation, and patients show some signs of RVH along with right atrial enlargement. So coming to the other thing, like a pulmonary embolism. So we can see in a critically ill patient. What are the various ECG findings in pulmonary embolism is the most common thing is a sinus tachycardia, because this is because of the hemodynamic instability it has. It doesn't reflect any hemodynamic alterations in the hemodynamic alterations in the RV contraction or an LV contraction. Because of the hemodynamic load on the heart, it is reflected as a sinus tachycardia. So what are the other things we see is S1 in lead 1, QT33, we call it S1 QT33. This is, of course, it is not even sensitive or specific for a pulmonary embolism, but whenever we think of pulmonary embolism, the first ECG sign we get into our mind is S1 Q3 T3 pattern. So this is the S1 Q3 T3 pattern. Like there will be a predominant QN3 lead 3 with the T-wave inversions, T-wave changes in lead 3. So this is the thing. If you look at the statistics, it is present in up to 18 to 20% of the patients with the pulmonary embolism. So what does it signify is, it signifies that there is a pressure overload on the RV. It doesn't signify there is a pulmonary embolism. So this is a sign with too much of attention, but with a less sensitivity and specificity. What are the other things we see is STT changes. Like all other conditions which have a overload on the RV or either RA or LV. So if at all any overload on the chamber is there, it throws some subendocardial ischemic changes, like in STT changes. There can be STT depressions, T-wave inversions. All these things can be seen. And the other changes are, we can have some amount of ST elevation in AVR, and a patient can have an RBBB, overall low voltage complex, or some elevation of ST segment in V1 with a pseudo infarct passion in 2-3 AVF. So these are the common findings, ECG findings in patients of pulmonary embolism. And again, to tell you, so the ECG changes, every ECG change need not be there in all the patients with pulmonary embolism. If the patient has at least 3 of the ECG changes, then we can think that the patient has a pulmonary embolism. First thing. Second thing, if the patient has a new onset of these changes, like if the patient has a predominant sinus rhythm with a normal pattern of activation in V1, and now the patient becomes tachycardic, unstable, hemodynamically unstable with the tachycardia with an RBBB, then we can think there is something happening in the right ventricle, some pressure overload over the right ventricle, probably a pulmonary embolism. So that second thing, that is important. If at all you see a new changes in the ECG compared to the older ones, then we can think in the lines of pulmonary embolism. So these are presentations like, so this patient doesn't have any right ventral branch block, but so this patient has a right bundle branch block presentation and right axis deviation. See, we can see 1 and AVF, predominantly negative complex in 1 and a positive complex in AVF, and a Q in V3, Q, T3, and T-wave inversions in V3. So this is one of the presentations of pulmonary embolism. The same thing, we can see a strain pattern like STT changes. Predominant T-wave inversions are there in the right side, V1 to V3. So that indicates there is some pressure overload on the right ventricle. And this is one of the things which have an interventricular conduction disorder and also an RBBB. We look at the V1, it is a positive complex in V1. So predominantly it has an RBBB morphology with an interventricular. The complex is so wide, so probably there is a interventricular conduction delay and also right axis deviation and a Q in L3 and also T-wave inversions. So this patient probably have a very fatal pulmonary embolism. So the conduction system also is very much affected. Probably this patient might have died. So the various presentation, the ECG presentations of ECG in patients with pulmonary embolism depends on the size and extent of pulmonary embolism. If the embolism is too big, the ECG will drastically change from the previous one. If it is so minimal, there may not be any changes also, or sometimes subtle changes just will walk through those changes. So on a whole, the ECG helps you, it indirectly helps you in diagnosing a pulmonary embolism. Like it should be accompanied with some other investigations like an echo or a CTPA to say that it is a pulmonary embolism. And as such, ECG, based on the ECG, we can just say it will be a probable diagnosis rather than a definitive diagnosis. So this is another ECG which shows there is a pressure overload on the RV with an RVH criteria satisfied and with the STT changes, what we call is a RV strain. So these are some of the changes pertaining to the chambers in patients with the pulmonary disorders like RVH, RAE, right bundle branch blocks. So these are some of the things. And now comes to the arrhythmias. What are all the arrhythmias? Because of the same reasons, same pathophysiology, because of the enlargement of various chambers of the heart, patient can have arrhythmia also. Like the RA is enlarged. Sometimes the RA or RV affected because of the enlargement of LA. So so these are the nidus for formation of various arrhythmias. And if you look at the mechanism of arrhythmias, what are the various mechanisms? I'm not going to touch in detail, but two mechanisms you need to know. So one thing is it can be a reentrant. So here the animation here shows the typical atrial flutter, where the entire RA is a part of the circuit. You can see that the impulse is traveling at a regular interval and in a specified direction. So it is taking a turn along the RA wall, and sometimes it is entering the AV node and activating the right vein and activating the ventricles. So this is a reentrant arrhythmia. So this we call it a reentry mechanism. And the classical example for a reentry arrhythmia is atrial flutter. So the other thing is atrial fibrillation. So here, what is happening is multiple impulses are originating from different parts of the atrium. Like it can be from the right atrium or the left atrium. It can be from the pulmonary valves, pulmonary ostium, pulmonary vein ostium, or from the roof of LA, or anywhere in between in the atria. So the impulse originates. This is a what we call it as increased automaticity or a triggered activity. So this is the another mechanism of arrhythmia. And the classical examples are atrial tachycardia or an atrial fibrillation. So these are the two mechanisms we need to know for knowing the arrhythmias in pulmonary patients with a pulmonary disorder. So if you look, so coming to the ECG presentations. So if you look at the ECG, what are you seeing in this ECG is basically it's an irregular rhythm. And the irregularity is also not regular. It is an irregularly irregular. I can't see any group beatings. I can't see any particular pattern in this ECG. Look at the QRS complexes. And I'm unable to see any P waves. Like if you look at the V1, you can think that these are the P waves. Sometimes we can miss, but these are coarse fibrillatory waves because they doesn't have any particular morphology which reflects the underlying P waves. So if you see any rhythm with an irregular thing, then most of the times it is a atrial fibrillation. So blindly we can say it's an atrial fibrillation. Patient can have a narrow complex or a broad complex, whatever it may be. But if the rhythm is irregularly irregular, the first thing that should come to our mind is atrial fibrillation. So the second thing, that is one of the arrhythmia we can expect in a pulmonary patients, like because the patients with the pulmonary disorder or a PAH or they have a atrial enlargement. So probably the patient can have atrial tachycardias or atrial flutters or atrial fibrillation, most probably originating from the right superior or right inferior pulmonary veins. So that is one arrhythmia, and this is the second arrhythmia. What we see here is a narrow complex, regular, and if you look at the QRS complexes, they are so regular, not even a single deviation. And that means whatever arrhythmia underlying mechanism is there, it is following a fixed path. There is no deviation, and it is following a fixed path. And also, if you look at L2, L3, you can make out multiple P waves followed by a QRS. Like if you see 3 P waves followed by a QRS, 3 P waves followed by a QRS, and the two sawtooth appearance. So this is a classical case of atrial flutter, wherein there will be the atrial rates will be around 300 to 350, where because the AV node is not that much good enough to conduct all the P waves, so it conducts only some of the P waves down the ventricle. So the ventricular rate will be around 150, most probably 150. So based on the number of P waves that are not conducted and based on the number of P waves that are conducted, we can classify it as a block, like 2:1 block, 3:1 block, atrial flutter with 2:1 block, atrial flutter with 3:1 block. So patient can have any presentation. Like patient can have even 7:1 block also. With an atrial flutter with a 7:1 block, like 7 PVs can be there, only 1 PV will be conducted to the AV node. So, and the other presentation can be with a variable block, because the AV node in an atrial flutter and a fibrillation, the AV node is so stretched, like it is so stressed, because it needs to conduct at a rapid speeds. Because of the rapid atrial rates, even the AV node has to conduct very rapidly. So the AV node is so stressed, it becomes, at some point of time, it becomes fatigue, and it gives away. It will be unable to conduct the impulses anything further. So at that time, patient can have a slow heart rate, like a controlled ventricular. What we call it is a controlled ventricular rate, is a slow ventricular rate. So that means even the AV node is diseased at that time. So these are the various presentations we can see. But the classical will be regular narrow complex tachycardia with a sawtooth appearance in L2, L3 areas. So this is the classical of atrial flutter. So the other thing is AT, atrial tachycardia. So I told you there will be enlargement of the right atrial chamber. So there can, which will be the nidus for the increased automaticity or a triggered activity. So there can, which results in atrial tachycardia. So if you look at the CCG, we can see different morphologies of P waves. So if you look at the baseline rhythm strip like 2 and V5, you can see at least more than 3 P wave morphologies. So that means it's a multifocal, because if the impulse originates at a particular point, the morphology will remain the same. Like the P wave originating from the SA node has a similar morphology all through. It doesn't have any change in the morphology. Whereas when the impulse is originating from other place, like it can originate in coronary sinus ostium, it can originate from pulmonary veins or some vein of Marshall, whatever. So many structures are there. It can originate from any other place. So in all such type, the morphology of PO changes. And if at all you are seeing more than 3 morphologies, 3 or more than that morphologies of P waves, that means there is a multifocal origin of the P waves. What we call it is a multifocal atrial tachycardia. Generally, it's the most common arrhythmia we see in patients with a pulmonary problem, like a COPD. But nowadays, we are not seeing that much, because patients are coming early in the early stages of lung problems. So the incidence of picking up a MAT has come down drastically. So this is one ECG, probably the last slide, which is confusing. Like what you see is a broad complex tachycardia. Definitely it's a tachycardia and the rate is around 150, and it's a broad complex tachycardia, and the rhythm to me appears very regular. So there is no periodicity or a regularity in the rhythm. So that is what I can make out. Generally, the patients with a pulmonary problem has a supraventricular tachycardias. Like SVTs are more common rather than VTs. But VTs also can occur if they have an associated LV disease, or if at all the RV is so diseased, then patients can have a VT also. Generally, VTs present as a wide complex tachycardia, and a supraventricular tachycardia is generally present as a narrow complex tachycardia. But there are exceptions. Like if the patient has an underlying bundle branch block, or if at all there is some aberrance in conduction, like what we call is an Ashman's phenomenon. Like in a patient with atrial fibrillation, if there is a long short cycle variation, so what happens is, because of the difference in the refractory period and conduction properties of right bundle and the left bundle, in ECG, what we see is the right bundle branch block morphology. All of a sudden, in a sinus rhythm with a narrow complex, suddenly we see a broad complex with an RBBB morphology in V1. This is because of this is what we call as a Ashman's phenomenon, and it is most commonly seen in patients with an AF with fast ventricular rates. The reason for this is difference in the refractory and conduction properties of right bundle and the left bundle. So coming to the CCG, what all I see is it's an RBBB morphology in V1, very irregular, broad complex. Probably there can be a small amount of pre-excitation if you look at L2, L3. So pre-excitation, that means, so, and if you look at V5, V6, there is a very regular broad complex. So towards the end, right side of the ECG, the complex has become more broader and it's an irregular. So from this ECG, what can I make out is probably the patient has AF. I already told you any rhythm with irregular periodicity. Think of AF first, no other thing. So probably patient has an AF. Maybe he might have had a pathway also. So AF is a deadly combination because the waves AF generally has an atrial rate of around 350 to 600. And the AV node is not that capable of conducting more than 200 or 250. So generally the rates are confined to general around 150 to 250. And above, more than that, they get blocked above the level of AV node. But in presence of a pathway, like pathways are just a myocardial fibers, extra myocardial fibers that connects from atria to ventricle. So they have good conduction properties. So they can conduct much faster and much better than AV node. So in case of AF with a pathway, what happens is some of the impulses travel through AV node and most of the impulses travel through the pathway. So the ventricular rate is not controlled. Like it is not, there is no limiting factor for the ventricular rate in such scenarios. Like the AV, even the pathway is there, the rates can go up to more than 350, 400. So that is what has happened here. Probably the patient has an AF with a pre-excitation with a pathway. So he has an AF with a fast ventricular rate, which later has degenerated into VT, probably VF also. So that combination is an emergency and we need to treat immediately. The choice of treatment will be an ablation. If at all that is not possible immediately, we need to maintain with the propionate beta blockers. So I'll stop here. So I'll wait for any questions and thank you.
Hi. Yeah. Thanks to Dr. Chandra Mouli, who has done this ECG so well. It reminds me suddenly we are going back to our PG days where we were asked to interpret the ECG. And moving forward, I would like all the panelists, Dr. Nilanjan, Dr. Supreet, and Dr. Chandra Mouli, to take the questions from the audience, and probably we will start our discussion from our end. Maybe we'll wait for their questions. I would. It was excellent talk by Dr. Chandra Mouli. And first of all, I would like to welcome Dr. Supreet. And Dr. Supreet, what
Yes,
are the common arrhythmias in pulmonary patients we see routinely in general?
Yeah. So first of all, I would like to thank CCI for giving me this opportunity, all the office bearers, and thanks to the Dr. Chandra Mouli for giving such a nice talk. So what are we usually see atrial arrhythmias and ventricular arrhythmias, as we know. Among the atrial arrhythmias, we have MAT, that is multifocal atrial tachycardias, and atrial fibrillation. But in a study, it has been found that when they evaluated patients with multifocal atrial tachycardia, they found that 55% of patient was having COPD. So the most common association in books, it is like multifocal atrial tachycardia in seen in patient with pulmonary disease. But in actual practice, what I see in my practice is most common rhythm disturbance or arrhythmias are atrial fibrillation.
Okay. And what are the precipitants or the risk factors for arrhythmias in these pulmonary patients, Dr. Nilanjan?
I'm working in the ICU. So in the ICU, I would tell that most of the patients like COPD who come, they usually come with hypoxia. Hypoxia itself, I would say, is a big precipitant of arrhythmias. Further, bronchospasm itself, refractory bronchospasm can also cause arrhythmias. And if you look at the medications that we've commonly prescribed to all these COPD patients, we give anticholinergics, we give beta-2 agonists, all of them can precipitate arrhythmias. And even if you look at salbutamol, which we give so commonly to our patients, they cause electrolyte abnormalities. They can cause hypokalemia. So electrolyte abnormalities are again another precipitant of arrhythmias, and that is what we see commonly. These are the common precipitants which I think come for our pulmonary patients.
Okay, apart from we should always look at the drugs what they are taking before. Usually if it's a cardiac patients, before we look at the drugs, and if it is a pulmonary patients, we look at our drugs, and most of them our drugs are causing the sinus tachycardia, atrial fibrillation. It's more of the tachycardia which is the issue. So what are the uncommon presentations what we see in pulmonary patients, Dr. Chandra Mouli, as a cardiologist, when you see in our pulmonologist referring, and you being a pulmonologist also, apart from Dr. Nilanjan and Dr. Supreet, what are the real uncommon stuffs we see in the pulmonary patients which we need to be aware of?
Generally, probably who are admitted in ECUs, probably a patient who has an underlying lung pathology or a lung disease, he will be having some amount of LV dysfunction also. So we need to look at both like LV and RV, and also as a few things. We also need to look at the electrolytes also, electrolyte disturbances, some hormonal changes like thyroid, hypothyroid, or any parathyroid hormone levels. All these things we need to consider, and we need to find out the cause for the arrhythmia, particularly in a patient who is admitted in ICU.
Okay.
Whereas in general practice, as Dr. Supreet has said, most probably it's an AF. And just I want to add one point here. So nowadays the school of thought is like AT or AF. It's the same pathology. Like if at all it is an AT, even if you look at the pathophysiology of AT, it is an increased automaticity from some particular points. Whereas an AF has multiple different points of origin. So a multifocal atrial tachycardia in the latter stages may degenerate into AF. Why is this important? Why is this important? Is because for an AF patient we need to give anticoagulations also. But as of now, the guidelines doesn't recommend anticoagulations for patients with AT. But in a patient with AF, we need to give an anticoagulation also. So we need to look at these things. Right now, the guidelines doesn't say that we need to anticoagulate patients with AT. But we need to think that MAT may degenerate into AF at a later stage.
Okay. So I would like to come to Dr. Supreet again. So we were talking about this tachyarrhythmias with multifocal atrial tachycardia to differentiate. Most of the time we look at the sinus tachycardia and we see there is a missing of P waves, and then we say it is AF. That's the most common things which we see. So then when we really look at tachyarrhythmias, what should be our goal? It's how exactly these tachycardias are classified. What exactly you need? You see the heart rate, if it is more than 120, it is more than sinus tachycardia. So to say it is sinus tachycardia only, or there is something more to it, what type of it, whether it requires further treatment, cardiology advice, how do you differentiate? How do you really classify and go about your job?
So usually we know that sinus tachycardia and the heart rate usually does not go beyond 180. That is the permissive limit. So if it is more than 180, we say that there is some it's not a normal sinus rhythm, and we should see what is the kind of abnormality or arrhythmia have. And recently there's a change in AF guidelines in 2014 American Heart Association. Previously used to classify AF as only lone AF, paroxysmal AF and all. But now the lone AF term has been given up, and now it is in classified with paroxysmal AF, which is self-terminating or resolved within 7 days. Atrial fibrillation, which usually does not self-terminate beyond 7 days and require electrical or a pharmacological cardioversion. Then we have long-standing AF, that long-standing persistent AF, that is persist for more than 12 months. And then we have permanent AF, atrial fibrillation, that in that case, patient and the clinician accepts that there is a AF and they no longer try to revert the rhythm, and they usually try to control the rate control. So that is what is the changes we have seen, and this is how we classify atrial fibrillation in today's era.
Okay. So when we really, Chandramouli, you want to add something on that?
One point here. This is a common scenario. Like patient may be having a sinus tachycardia, the rates around 170 to 180. So probably we'll be confused whether it is an SVT or a sinus tachycardia. Then the first and foremost thing will be the clinical scenario and the previous ECGs. So if the patient has any new onset of pseudo S waves or pseudo R waves in the ECG or any T wave changes, because at a rapid rate like at around 180, 170, sometimes we may not be seeing the P waves because they'll be falling under T waves. So at that time it becomes difficult, but we need to look at these subtle changes like a pseudo R wave or a pseudo S wave, which goes more in favor of an SVT rather than a sinus tachycardia. But the foremost important thing is the clinical scenario we need to look at.
Okay. So it's really tough for us like a pulmonologist who would have seen more of PFTs and other things. When they look at sinus tachycardia, we see a lot of patients who come with sepsis, and that time we have a tachycardia. They are tachypnic also. Sometimes we are worried whether it is a cardiac, whether it is a pulmonary embolism, and this thing. The clinical setting is most important. So if there is a fever, sometimes the fevers are by just giving the paracetamol, most of the time it will improve. So we should always take the background history, which is more important. And when we really look at ECG, most of the time we always don't have to jump and this thing. If you spend the time with a patient, most of the things can be corrected. Sometimes a simple carotid sinus massage can differentiate between supraventricular and ventricular stuff. So what exactly this P pulmonalis, why we have to look at the P wave? P wave is a concern for the right heart. Right heart, whenever we look at it, is more of lungs. We see the cor pulmonale and we manage it more, and we see once we detect it as cor pulmonale, we look at all other causes, right from obstructive sleep apneas to chronic lung disease or vascular disease and all. So this we looking at a P wave becomes more important. How exactly what is that exactly, the P wave, P pulmonale? What are the differential things we need to look at when you really look at tachycardia, Dr. Nilanjan? How exactly it will change the management, looking at the P wave, absence of P wave? How exactly what we should look at when we really see the rate? Rate we actually is being seen. We will see a rhythm strip, and what exactly we need to see continuously when there are missed P waves and tall P wave, broadened P wave, or M pattern, whatever is it. Dr. Nilanjan?
Yeah, so what we see is when we do a routine ECG, suppose a patient has come, a COPD patient has come, or any patient has come, we do a routine ECG and we have seen a P pulmonale. So in this case, we have to, now it's a case where we need to think beyond COPD, like now the right atrium has been involved, right? It's a P pulmonale basically signifies right atrial enlargement. So right atrial enlargement, it may not be only in COPD, it can be in any chronic lung disease. So management wise, what I would do is perhaps we should add diuretics, we should add a bit of Lasix. And another thing that I would certainly like to do is I would like to get an echo done for this patient, because perhaps because of right atrial enlargement, certainly he must be having a bit of elevated PA pressures also. He must be having pulmonary artery hypertension also. That needs to be elevated. That needs to be evaluated. And if pulmonary artery hypertension is there, then again we might need to add pulmonary vasodilators. We might need to add a little bit of sildenafil. So yeah, P pulmonale carries a very significant change in our treatment. We'll have to evaluate further. The cardiac evaluation becomes very important.
Okay. See, apart from this, routinely what we see, and most of the time it is domain with the cardiologist, and we usually be happy referring to the patients with the tachycardia to the cardiologist. So they pick up something more than what we do in routine, and they try to put in, sir, we are happy with atrial fibrillations and all. Sometimes they just go deep into it and find out what are the really uncommon form of tachyarrhythmias apart from atrial fibrillations, apart from MAT, and we see something rare, something we detect which is unusual in once in 2-3 years and all. We see that ECG. We are happy that we have picked it up. So we will not be bothered about the management. We will be running and showing to our residents and seeing a cardiologist to ask what exactly is it. What is those rarest tachyarrhythmias which you see in once a while? Dr. Chandra Mouli?
So rarest will be like a very rare pathway or an accessory pathway, probably a PJRT, paroxysmal junction reciprocating tachycardia. So it is a specific pathway where it has only a retrograde conduction, that to a slow decremental retrograde conduction property. That means it almost behaves like an AV node. So if you look at the impulse that originates from the SA node, travels orthodromically through the AV node, again it goes back through the pathway and catches the atrium again. So it becomes an instant tachycardia. So probably this is the rare thing. It is one of the rare things.
Okay.
But not in particular to the not in particularly a pulmonary patient.
Well, we should be exactly aware when we are overlapping seeing the patient in the hospital, where exactly to take the inputs. Sometimes we disregard if there is associated fever with that, and we disregard that. That is more important. And I personally have one of my auntie been suffering. She used to have giddiness, gone to hospitalization for 10 times. I didn't know what exactly is happening to her in a small town. And after we came, and when it came to a bigger city and all, she actually has WPW syndrome, and they actually did the radio frequency ablation. So we never know. So exactly we look at the ECG and all. I was really perplexed because 10 years they were telling, and they go to hospital and they come back with whatever treatment and all. Nobody digs deep into that. And those things have made me aware that seeing the ECG, we need to reconfirm when there is a P wave is there, P wave is absent, whether it is AF only, we need to reconfirm it. Okay.
Yeah, we need to look at different intervals, like retrograde P wave is there. See, only on repeated observations we can make out. Probably
so we need to keep seeing the ECG, even if you don't get all the measurements and all. If you see, that pattern gets imprinted.
At least
so
to have
mind. So general measures in the management of regularly in tachyarrhythmias, Dr. Supreet. What are the general measures we look at in management? So we'll go into one step more in management, which is more important because that gives happiness for a clinician who is practicing. So when you really talk about management, when you think about the SV node, AV node, and blocks, the blocks and all, we go to physiology levels. So what we need is when we really get the diagnosis, what exactly is the simple things from your end we can do before the cardiologist comes in and taking a discussion to a next level.
So I think first of all, we should know what is the cause. Like a pulmonary patient, hypoxia is the most common cause. So we should try to correct hypoxemia. And if patient has hypercapnia, so bronchodilator as a mainstay of therapy. Then second thing is what is the precipitating cause? Patient has acute myocardial ischemia, some cardiovascular disease, hypertensive heart disease, or patient has electrolyte imbalances, metabolic acidosis, probably hypokalemia, hypomagnesemia we should look for. And then we should avoid when he is receiving any drugs which prolong QT prolongation, like azithromycin, and we have seen at
macrolides.
COVID-19, we have seen lopinavir, rotenavir, iconazoles. And the fourth important thing is very important, which pulmonologists commonly using is theophylline. So those patients who are on a long-term chronic therapy, they should measure the theophylline levels. Previously, the theophylline level were like 10 to 20 micrograms per ml, but now this range has changed, and they have seen that all the beneficial effects can be achieved at low dose theophylline, and which is between around 8 to 12 micrograms per ml. So I think we should, if patient is having these arrhythmias, we should try to discontinue theophylline therapy, measure their levels, and avoid the drugs which are long QT, and optimize the primary disease management.
Okay, thank you, Dr. Dr. Supreet. And how exactly we manage AF per se, Dr. Nilanjan, when you really come to conclusion that it is AF only and it is not SVT. SVT, we know that there are umpteen causes, even pain can cause, even Many things can cause sinus tachycardia, fever and all. They are simple things. If you symptomatically manage just reassuring the patients and treating the primary cause, the heart rate comes. We have seen in the COVID times also, when they are recovering, when they come on a follow-up of post-COVID fibrosis and all, the heart rates are always around 120, 130. They are worried about it. We have used simple avabradine and other things, and slowly over 3 months or 6 months of time, they come to 80 or 90 heart rate. So how exactly you manage atrial fibrillations along with the cardiologist in the hospital?
Yeah.
So what exactly the
So,
management issue? So if it is a short duration, we have to just sometimes it will disappear. We have to wait. How long we have to you have to wait really to start an anticoagulant? Why we need to start an anticoagulant or this thing? Real management of AF.
what I would do is, suppose a patient walks in, or suppose a patient comes with an AF. So basically, first of all, you have to confirm it is AF, and then after that, I'll, as Dr. Supreet told, look for just a quick look for any precipitating factor. Perhaps I would do an ABG. An ABG would give me some of the electrolytes, whether there is an acidosis, or whether there is a respiratory acidosis or a metabolic acidosis, something like this. And okay, so once it is an AF, then I have to look whether the rhythm is unstable or it is stable, whether the patient is hemodynamically stable or unstable. So usually, if most of them are stable, they are hemodynamically stable. So I would start with amiodarone. I would give a bolus of 150 mg amiodarone for them, and then I would continue an infusion. So one
24
thing I would
hours.
like to
Okay.
tell is, like, for if it's a non-pulmonary patient, for a non-pulmonary patient, I would, after a bolus of amiodarone, perhaps I would try a beta blocker, and I'm sure Dr. Chandra Mouli will also, cardiologists always like giving beta blockers. So
So
the
invariably
problem,
in our practice,
yeah,
when somebody has been started on aminophylline, it will be followed by cardrone.
yeah.
So
So
infusion. So when we treat really bad asthmatics, most of the time we have seen that cardrone has also become a drug of choice when you are
yeah,
treating an asthma in a bad asthmatic patients. Yeah, I agree with that. Yeah.
yeah. So the problem is, we actually, for a non-pulmonary patient, perhaps we can give a bit of beta blockers also. It will settle the rate. But for our COPD patients, they might go into severe bronchospasm. So that is one management which we have to take out from our regular cardiology textbooks. And so we should settle with amiodarone. Give amiodarone 150 mg, and then perhaps an infusion of 1 mg per minute over 6 hours, and then zero point 0.5 mg per minute over the next 18 hours.
Okay.
Yeah,
So if it is
if I would say
unstable,
that
most
is,
of the time they might require a
we'll
shock
have to
or anything.
cardiovert. We'll have
Okay.
to give a synchronized cardioversion. And if it has been a short duration, it's okay. There's no need of further anticoagulation. But if the patient has been a patient having recurrent AF, then anticoagulation is required, especially if the AF has lasted for more than 48 hours. Then yeah, we'll have to anticoagulate the patient.
So why we need to anticoagulate AF patients with more than 48 hours, Dr. Chandramouli? Why we need to give anticoagulant in AF? Why
Uh,
there is a necessity?
Yeah, a few points. In addition to the question what you asked, I'd like to add a few points because see, in a hemodynamically unstable patient with an AF, the first choice will be treatment of choice will be a cardioversion. But before cardioverting any patient, whether it
Good.
is a cardioversion or it is a this DC cardioversion, whatever it may be, say do a TE first. Do a transesophageal echo, rule out an LA clot, left atrial clot or an
Excellent,
LA.
excellent point, sir. You know, when we really look at unstable patients, we need a transthoracic. Sometimes transesophageal will be tough before
Yeah,
cardioverting because actually you are making the things worse. So rate control is good and shock is good. We have to always
yeah,
give a shock in the absence of a clot. I feel that's the message.
yeah. So before rule out the clot first because we'll be doing more harm by giving a shock to a patient with an LAA clot because he'll be having a large embolus and he may have a very big stroke. First thing. Second thing, because the in an atrial fibrillation, what happens is the contractions of LA are not proper. The LA atria will be just fibrillating because because of that fibrillations, there will not be any effective forward flow of the blood. So there will be a stagnation of the blood, particularly in chambers like LA appendage. And even LA itself is a very low pressure chamber. The pressures in LA are very low. So because of these factors, there will be stagnation of blood, which leads to formation of clots. So for this reason, we need to anticoagulate the patient. And whom to be considered for anticoagulations in patients with AF is, we need to look at a CHAD-SWAS score. There is a score called CHAD-SWAS score. So based on the score, if the score is more than 2, we need to give whoever the patient may be, whether it is a valvular or a non-valvular, irrespective of that, we need to anticoagulate the patient. If the CHAD-SWAS score is less than 2,
Okay. Okay.
so it will be less than 2 when he doesn't have any risk factors and the age is less than 65.
Okay.
So if
I
he doesn't have
agree.
any,
I agree completely. AF management, it's first the rate control. If he's unstable, it's better leave it to cardiologist to come and have a discussion and let him get his technician to do a transthoracic, actually transesophageal. It will be something more. If there is a unstable, it's going to be very tough. By the time they would have been intubated, probably required some other things. But if they are really stable, probably rate control should be the answer first, and anticoagulation we can take a time and doing a transthoracic echo and add an anticoagulant based on other parameters. And how exactly, see, apart from this cardron, we are used cardron, and once you use 24 hours, it is 150 mg BD, long duration and all, they are taking cardron. And of course, we see a lot of cardron induced lung disease. Sometimes they are chronically taking it. That's a different issue altogether. But this non-AF SVTs and other things, sometimes they affect the oxygenation in a septic patient on a ventilator when they are borderline with ARDS and all. We want this heart rate to be coming down. So we are not happy seeing the monitor 130 and making that sound, twing sound. So we want some heart rates to be coming down. So which are the drugs which we use apart from cardron to really get it down? Dr. Nilanjan or Dr. Chandra Mouli. So like we have ivabradine, which is being used. This thing we have beta blocker. We are unhappy whenever we write beta blockers. We always look at the COPD or asthma. This thing. So which are the other drugs apart from the cardron or amiodarone?
One thing I'd like to mention here. See, if you look at the management, no, we can classify the drugs into 2 things, like a rhythm management drugs, the drugs which control the rhythm, and the drugs which control the rate. Both are different. So if you want to control only the rate, then we need to give the drugs that acts on the AV node. Like what are the drugs that are available that acts on the AV node are beta blockers, calcium channel blockers, and digoxin. So these are the 3 drugs. And coming to beta blockers, so nowadays we have cardioselective beta blockers. Like of course landiolol, one of the latest drug is a landiolol, which is not into the market yet, but it has a 1:1200 at least. The beta selectivity, cardioselectivity is 1:1200. When it comes in comparison, propranolol has 1:1. So that much cardioselective beta blockers has come now. So even beta blockers can be given in patients with COPD with so much of
like nebivolol is used.
More cardioselective.
Smaller is used.
Even bisoprolol.
What about ivabradine, Dr. Chandra Mouli? We keep on adding.
Ivabradine is contraindicated. Ivabradine is contraindicated in AF.
Okay.
We should not give.
So in sinus tachycardia, we can use.
So that's what I am coming to that point. Nowadays, no, in this COVID time, we are seeing more of sinus tachycardia. What we call that is an inappropriate sinus tachycardia. So this is one of the type of supraventricular arrhythmias. The incidence before COVID era was low, basically. But now after this COVID, most of the patients with a tachycardia, we need to consider inappropriate sinus tachycardia. So in such patients, the drugs of choice will be either a beta blocker or an ivabradine. And what is ivabradine is, it acts only on the funny channels that are present only in the SA node. So it doesn't act anywhere in the heart. So by giving, what happens in a patient with AF, by giving an ivabradine, we are suppressing the SA node. That means we are promoting AF further because the SA node is all suppressed. So that's why it is contraindicated in patients with AF.
Points taken actually, because we also used to add ivabradine for sinus tachycardia. We need to look at more careful being ivabradine, especially because thanks for making aware of those small little facts. And I would like to come to Dr. Supreet. So regarding anticoagulants, in the hospital we use injectable or like anticoagulant, like it can be heparin to enoxaparin to newer anticoagulants. which are available.
NOACs.
NOACs. So there is dabigatran, there is this apixaban, and there is a rivaroxaban, and all. Now we have been in last 2 years of COVID. All pulmonologists and especially even in MBBS doctors, in anticoagulants awareness is so much, and people are prescribing left and right anticoagulants with D dimers elevated. So how exactly you choose anticoagulants? Certain anticoagulants like warfarin are absolutely wonder which patients to choose for warfarin, which patients to choose for NOACs, and how exactly you choose this thing. Especially in hospital, we use the Clexane. I'm not talking about pulmonary embolism. When you are treating an OPD or AFs and other things, how exactly you choose your anticoagulants for what patients in heart in picture?
Yeah, so NOACs has eased the management little, and our
before going to a regular ones, where exactly because certain indications are still there for warfarin, and we have to specifically. I want this message to going to a general public.
Yeah,
exactly. We can't use NOACs. We can use only warfarin.
So warfarin is usually used in valvular heart diseases and not in other. But these NOACs, they are absolutely contraindicated in valvular heart diseases. So their absolute contraindication indication, valvular heart, they should not be used. I think severe MS and all, breastfeeding and lactating women. So NOACs should be avoided in this group of patients and also in the patient with severe renal failure. These are the group of contraindications we should remember. So in valvular heart disease, warfarin is the only indication. Other you can use NOACs, heparin, and all those things. And among the NOACs, the most commonly studies are with rivaroxaban and dabigatran, and the most commonly used is rivaroxaban. Dabigatran is very useful in elderly group more than 80 years, and also but dabigatran only one contraindication those who have upper GI bleed. So there's subclinical bleeding, GI bleed is common with dabigatran. So you should be carefully using in those with elderly, but in more than 80 years, it has been seen in studies that elderly more than 80 years, dabigatran is better than.
What's the dose? You need to be dabigatran dosage in elderly. We need to be when it is therapeutic dose. We are talking about. Can you just highlight on that also in terms of dabigatran, because the message has to go loud.
Yeah, I think Dr. Chandra Mouli can add about this newer anticoagulants along with.
Yeah, when it comes to NOACs, so as Dr. Supreet has already told, so the only indication for not giving NOACs is a valvular heart disease, and right now we consider anything above moderate MS.
Okay,
that is the only valvular heart disease where we definitely need to give vitamin K antagonists.
Okay.
Otherwise, we can give NOACs in any patient. Okay. Like if but some exceptions are, we need to look at the hepatic functions or the renal functions. Even in a patient with a renal impairment, if the eGFR is around 30, more than 30 or around 40 to 50, we can give some drugs like rivaroxaban we can give, and apixaban we can give. Only thing is, above 75 age, apixaban dose has to be reduced to half. Like the general dose we give is 5 mg BD for apixaban. We need to reduce it to 2.5. When it comes to dabigatran, we need to look at the hepatic function. And the dose is, say 2 doses are studied, 110 mg BD, 150 mg BD.
175 is also available, I feel.
But that is not the recommended dose actually. So 75 is also available, but the recommended doses are only 2, 110 mg BD and 150 mg BD. So you can as well start with 110 and gradually upgrade to. Whereas when it comes to rivaroxaban, it is two doses are available, like 15 mg and 20 mg. I prefer the maximum dose. And as a cardiologist, now we are giving even 2.5 for a coronary patients with an ACS, coronary artery disease also, we give rivaroxaban. Now recent trials have come like COMPASS and all, where we are combining antiplatelets with anticoagulants with so rivaroxaban.
We can give antiplatelets and anticoagulants at full doses if there is a risk factors are there.
Yeah.
Or we have to reduce the dosage, like if they are using ecosprin or if they are using clopidogrel. So when we have to use the therapeutic dose, how exactly you go about? Because you stop
that depends on the clinical scenario and what is the treatment modality he received. If the patient has received a stent, say for example, he has received a drug-eluting stent, then we need to give dual antiplatelets. If you want to add an anticoagulant, like in COVID era, we are seeing more of a thrombotic lesions, thrombotic occlusion, coronary occlusions. So in such patients, adding a rivaroxaban definitely helps the patient. So at least for 1 month, we give 3 drugs. After that, if you want to stop, we stop ecosprin, continue with rivaroxaban and a clopidogrel. Because the combination works better rather than rivaroxaban plus ecosprin.
Okay,
So,
as you mentioned, yeah, it's a good point. And as you mentioned, this COVID patients, and I would like to ask Dr. Nilanjan because you are seeing more patients in ICU, and we have seen a COVID presenting with already with pulmonary embolism. So we normally used to do in CT and seeing scores and other things. If the hypotension is unexplained, we are doing a CT angio. We have a GGOs which are 16/25, and we have already have a pulmonary embolism. So we sometimes we risk benefit of thrombolizing is there, and sometimes underlying COPD is there. So first thing what we detect is before going for a HRCT, we are doing it more in a ER when they present with hypotension and all, with the creatinine and with the transthoracic echo, if the PAH is high. So which PAH we think that there is additional cause if the COPD after all the treatment. We have a suspicion of PE. How do you really these things? Because both are breathless. On a OPD, sometimes we detect a pulmonary embolism. If they are come with sick, and when we should do, we will be thinking of treating COPD more, and we might be advanced disease, and there might be an additional problem if there is a disproportionate pH. So how do you suspect PEs in COPD patients?
So, unfortunately for COPD patients, it's really difficult to diagnose. It's compared to the general patients that we have, it's extra difficult. Suppose they have come to our ICU with breathing difficulty. So the first thing that we do, yeah, we'll definitely do an ECG and we'll send a tropi and we will send a D-dimers. So D-dimer, it's what I would say is it's an important negative test. If we have a normal D-dimer or a negative D-dimer, I can say, and the patient has a lower risk of having a pulmonary embolism. But even if the D-dimer is slightly elevated and the tropi is elevated, then again I am in a dilemma. So COPD itself, it's been classified as a risk factor. Even if we take the well scoring, which is used for pulmonary embolism risk stratification, even if we take the pulmonary embolism severity index, COPD has 1 point for it. So the next thing that we can do is an echo. But again, for a COPD patient, they might be having a pre-existing RA-RV dilatation. They might be having core pulmonary. So again, echo we cannot 100% or even at what I say is 50% say that this patient is having pulmonary embolism just based on a D-dimer and a echo. So ultimately, we'll have to go for a CT pulmonary angio, I guess. And I think that is the only way that we can differentiate for a COPD patient.
Yeah, in a low probability of the PE and DVT and pulmonary embolism and D-dimer as a negative predictive value, and you can rule out DP and this thing. And strangely, so in last 2 years, this much D-dimer reports I have not seen in my lifetime. So these many D-dimers, whether it is what kind of method, it is 500 to 1000, there is no guidelines how long we have to give anticoagulant. So people are coming with the D-dimers elevated. So D-dimer positive doesn't have any significance. So if it is positive, we need to still evaluate and rule a DVT probably.
Definitely.
Or sometimes we have to do a lung perfusion or a CTPA. So this D-dimer has become a big menace, I feel. I feel we have to give importance to negative D-dimer. We can be confident. But this positive D-dimers, I don't know. There should be a point of care testing or something new has to be coming into picture. And how do you deal with this D-dimer with this COVID? I don't know how long we have to give. And what I do is principally do the D-dimers and monitor it for a few days. It can be acute phase reaction. Many pregnant women are having in CKD patients. It's high, and sometimes since patients are happy taking anticoagulants to this because people know everything about D-dimer now. So they come with a higher D-dimer. So we have to give a BD dose, twice dose, 3 months. There is no guidelines in COVID, especially for COVID and D-dimer and how long we have to give. What's your take on Dr. Chandra Mouli? How should we answer our questions? I think it will be helpful to whole pulmonology society in India.
Sir, as you rightly said, no, as there is no proper guidelines regarding this, it's all individual experience only what we have right now. So,
Probably the Cardiology Society has to come up with the guidelines. If there is in a COVID situation, this is the number of days we should take an anticoagulant and then retest it, because people are testing it every weekly.
Sir, if the patient has no other risk factor except for COVID, that means we can stratify him in a low risk patient. We can continue for 28 days or 1 month. If the patient has some other risk factors like diabetic or a renal failure patient or already patient with a heart failure, all these risk factors are there, we can continue it for 3 to 6 months. Generally, that's what we follow in, but I don't know.
It is very difficult on ground. And we give it for 1 month, 3 weeks, seeing the D-dimer, and we learned, and first wave, second wave, now the D-dimer role and steroid role is less in the third wave, and we are happy for it. And what are the arrhythmias which we see in COVID-19 patients, Dr. Supreet? What you have seen most in cardiac problems in this COVID?
So in COVID, I will like to divide it into active COVID and post-COVID. So in active COVID, we have seen usually, atrial fibrillation is the most common arrhythmia, and followed by ventricular arrhythmias. And the reason for these arrhythmias is most common is hypoxia, dyselectrolytinemia, myocarditis, myocardial ischemia, hyperinflammatory state. So hypoxia, because the hypoxia leads to increased epinephrine release and leads to atrial fibrillation. And it was in active COVID, it was seen more in those who are elderly, those who had comorbid condition like diabetes, hypertension, coronary artery disease, or hypertensive heart disease. But coming to post-COVID, as Dr. Chandra said, in post-COVID, we saw a lot of people were having tachycardia post-recovery. So that is that they have given a term. My friend is there, Dr. Kunal Shekhar. He has done a studies. He's Dr. like Chandra Mouli. He has also done MD Pulmonologist, and he is also a cardiologist now. So he has done a few studies and has published in Circulation Journal, European Respiratory Journal, that is called POTS, postural orthostatic tachycardia syndrome. And they found that these were more common, that is, rise in heart rate by 30 per minute without, in the absence of orthostatic hypotension. So when people get up from supine to, when they walk, so they get tachycardia, what they call as inappropriate, or the term has been given for this, postural orthostatic tachycardia syndrome, POTS. So in that case, it was seen that this was unusual. This was seen in those who do not have any cardiac disease, and it was seen in young people. And there's another thing was heart rate variability. That also they studied, and they found that because heart rate variability is a non-invasive marker of autonomic dysfunction, cardiac dysfunction. So they found that those people who had lower heart rate variability had more cardiac autonomic disturbances like tachycardias and all. And the treatment is usually, reassurance and ivabradine was the most commonly used drug. So these were the things pre-COVID and active COVID and post-COVID. So in post-COVID, we saw this tachycardia, what is called a POTS, and decreased heart rate variability leading to cardiac instability and autonomic dysfunction.
Yeah. This autonomic dysfunction is the cause for most of the deaths probably in the first and second wave. Because we were talking to initially, we were very confident as a pulmonologist in managing the ARDS and managing getting them to a tracheostomy, weaning them. And most people, we thought that this fellow will go out. And we have seen he's completely conscious, awake with tracheostomy, pneumothorax being corrected. It's on 51st day or 30th day of this thing. Suddenly, there is an unexplained hypotension and a tachycardia, and patient is gone in COVID. So we started giving too much bad prognosis for them. And this is not happening in the third wave, which is, it's very, this is unexplained cause. I feel in first and second wave, all would have seen. And I lost confidence in my own field that whatever I am doing, I am not going to tell the patient is going to survive at all. When it comes to ICU, things which we thought that they are going to die, definitely they have improved. Those patients we thought that we are going to survive, they have died. So probably this this COVID has taught a lot about rhythm and autonomic dysfunction, and it used to happen in long-term ventilated patients in autonomic regulation in retroviral disease patients. But this in COVID, this we are seeing the rhythm disturbance. We see morning tachycardia, evening bradycardia. Those things were happening. We don't know, in spite of this thing, that was a major sign of autonomic dysregulations. Moving forward, so we talked about a lot of tachyarrhythmias and all. So bradycardias usually in severe hypoxia, it is usually pre-terminals. Bradycardia we see in code blues and other things. We are not talking about those things. How exactly we go about dealing with bradycardia? What we should look at the bradycardia? What exactly is the bradycardia? Some are athletes and all, we see 50, 51 rates, and sometimes we should be very careful.
1 second, sir. 1 second. Sir, 1 second. 1 second.
Yeah.
Sir, can you hear me now?
Yeah. It's, we are talking about the bradycardia. What exactly, apart from this code blues and other things, what are the things which we look at bradycardia in general, sir?
Sir, bradycardia, whenever you are seeing a bradycardia, just look at the rhythm, whether it is a sinus rhythm or something else. If it's determine whether it is a sinus bradycardia or something else, or a conduction block like AV block or an SNodal block. So first thing we need to do that. Then we need to look for the correctable causes of bradycardia, like a patient with a hypercapnia may be having, or some dyselectrolytemias, they may be having bradycardias also. And sometimes disturbances, say hyperkalemias and all, they have bradycardia. Apart from the sinus bradycardia, they can have even AV blocks also. So first and foremost thing we need to consider is look for the correctable cause, look for the rhythm, and if you are sure that it is not sinus bradycardia and there is no correctable factor for it, then the other option left will be looking for the hemodynamics. If the patient has hemodynamic instability because of this bradycardia, the immediate thing we need to do is put a temporary pacemaker. If the patient is hemodynamically stable, we can watch, and later we can refer for the permanent pacemakers. This is how we approach a patient with a bradycardia. And particularly in this COVID era, we are seeing COVID as such. Probably the bradyarrhythmias are less compared to tachyarrhythmias. But in a dengue era, when it comes to patients with dengue, we often see patients having bradyarrhythmias. Because in such, probably this may be a myocarditis, one presentation of myocarditis. The virus might have affected the conduction system. So there is a defect in the conduction system properties, which is the reason for bradyarrhythmias.
So before really looking at the bradycardia, Dr. Nilanjan and Dr. Supreet, what are the exactly the drugs which we need to look at if you get a bradycardia before calling to a cardiologist? There is a bradycardia. So what are the things you ask in terms of history, or what exactly you say this bradycardia, it's sinus bradycardia, we can ignore it? Or when you really dig deep, you can see a metoprolol or atenolol which is there into the system. Sometimes they are icteric, they might have a bradycardia. So sometimes they might be at sleep. No, you see a bradycardia on the monitor. No, you wake them and it will improve. So what are the drugs and what are the things which you look at, Dr. Supreet and Nilanjan? I think you can both answer. Drugs.
Yeah, drugs as usual, sir. You would see mostly beta blockers, calcium channel blockers. Most of them would be on might be hypertensive, so they might be taking some form of antihypertensive. So we'll see that, and even they might be having they might be on amiodarone, some antiarrhythmic drugs. These can also cause bradycardia. So I think probably many of our post-COVID patients, they are on Ivabrad, they are long-term taking Ivabrad at home. Suddenly they might also come with bradycardia. So yeah, I think for a pulmonologist, I think these are some of them that we really need to see, especially in this COVID area.
So which bradycardias we think that how exactly you come to conclusion of whether CHB, whether it requires a temporary pacemaker or a permanent pacemaker before you come on, we can this thing, there's no shocks and other things are required in bradycardia. It's usually a pacemakers and who require a permanent pacemakers and other things. After ruling out, how exactly you come to you need electrophysiological studies for that, or you just need how exactly you go? But I know for electrophysiological studies are required for any kind of rarer things in tachyarrhythmias. In bradycardia, how exactly we go about
bradycardia, as I told you, if at all there is some underlying AV block, AV nodal dysfunction is there. Like if he has a complete heart block, that means at a type 3 AV block, or if it's a high grade AV block, so then definitely we directly go for a pacemaker. Initially, depending on the hemodynamics, we go for temporary to permanent, or directly a permanent with a background support of temporary. That's how we go, sir, in bradyarrhythmias.
Okay.
And sir, other question, I forgot about the other question you asked.
No, CHBs and bradyarrhythmias, after ruling out these drugs and other things, if there is no clinical problem. One of the things we should be always aware is athletes and who already have their heart rate
Yes,
always.
sir. They have a sinus bradycardia. That's why looking at the ECG is important. Electrophysiology. I thought of telling.
Electrophysiologist is not required much in bradyarrhythmias. That's what
No. In bradyarrhythmias, it is not important, sir. Only thing when we have a confusion, just we need to see if you are confused whether to give a permanent pacemaker in a patient with a lesser degree of AV blocks in the, then we do an EP study to determine the HV interval, like his to ventricle interval. If it is more than 100, then it becomes an indication for a pacemaker. That is the only indication of EP study in a patient with bradyarrhythmia. Otherwise, there is no role of EP study.
EP, I would like to highlight these EP studies are specific studies conducted by electrophysiologists when they have an event of arrhythmias. They do a specific studies where exactly the channels are there, and then they decide what are the proper therapies. And the most important therapy where electrophysiologists are definitely involved, because even cardiologists, they co-manage their patients with electrophysiologists. And one of the thing is radio frequency ablations. And this is one of the therapy. I would like to highlight this because we need to know a bit more about, as we know, we are entering into more of intervention era in our pulmonology. Sometimes we need to know, there might be some questions we need to, just in general, how exactly, what is radio frequency ablation? In few words, Dr. Chandra Mouli, in which conditions we do and all.
So, generally, radio frequency, now I think it's a treatment of choice for any arrhythmias. Like take, for example, an SVT or the VT. So, if it's an SVT, we can classify it as an AV-NRT, like AV nodal reentry tachycardia or an AVRT, atrioventricular reentry reciprocating tachycardia. So, that means an accessory pathway, what we call it is the WPW syndrome. So, these are the definitive indications for an radio frequency ablations. And other arrhythmias where we generally consider is atrial tachycardias. If the patient is too much symptomatic, like for an AV-NRT and AVRT, we do on a regular basis. Ablation we do on a regular basis because those are the treatment of choice. But when it comes to patients with an atrial tachycardia or a patient with AFs, we look at the clinical scenario also. If the patient has an LV dysfunction, or if the patient is too much symptomatic, if he is symptomatic, like if he has a class 2 dyspnea or class 3 dyspnea, or he has severe symptoms of palpitations, then we consider taking him for ablations. That is regarding SVT. Whereas when it comes to VT, definitely ablation helps.
Okay. And there is a question from Dr. BP Agarwal, Uttar Pradesh, Prayagraj. In bradycardia, first we should give isoprenaline infusion rather than directly going for a pacemaker. Dr. Chandra Mouli, please. That is his question for you.
So I don't think so, because see, I don't think so it is required. Again, the clinical scenario comes. If you think that AV node is only partly dysfunctional rather than diseased, and if you want to test the AV node, then we can give these drugs like atropine and isoprenaline. But if you are sure that the AV node is diseased, then there is no point in giving those drugs. Like I'll tell you one scenario: the patient can be having vagally mediated bradycardia also. Like the vagus will be acting on AV node, and because of the vagus overactivity, the AV node is suppressed, and it will not be conducting properly. Then also we can see some blocks. If you are suspecting that scenario, then we can give those drugs like vagolytic drugs like atropine. Or we need to stimulate the node, like by increasing the beta stimulation with isoprenaline. So all these drugs we can use. But otherwise, for a classical case of complete heart block or a high grade type 2 AV block, we need not give isoprenaline. Directly we can take the patient for a temporary pacemaker or a permanent pacemaker.
Okay.
And moreover, these drugs won't act in the infrahisian level. Like if the block is, if you look at the conduction system, there is a bundle of His followed by a pathway, a conduction fibers, which divides into bundle branches. So these drugs won't act at the infrahisian levels. All these drugs act on the suprahisian level only. So if the block is infrahisian, there is no point in giving atropine or isoprenaline.
Okay. Okay, points taken, Dr. Chandra Mouli. But I would like to say this vagal system. I recently got one of my aunt for gastric surgery, esophageal pull-up surgery, where egotomy is done. So that time, most of the patients, they have tachycardia.
Yeah.
That is a permanent issue, a permanent problem, right? Post surgery, if the vagus is not active.
Yeah, they have tachycardia.
So these are the clinical scenarios or the small little questions which can solve the issues. You don't have to give evapradine and other things. So these are small littles like drugs and all. I just wanted to highlight that we can still do a lot of things with history before getting into the cardiologist domain. So I would these pacemakers and arrhythmias, these are being well taken. One of the burning issues for the pulmonologist, I agree with Dr. Supreet and all. And this sarcoidosis incidence is more in our pulmonology practice, where we are bothered. Even anesthetists, when they are taking any sarcoidosis patient for any problem, they do their ECGs and all, because conduction problems, sarcoidosis and other things, they are been pretty aware of that. So how exactly see what are the conduction problems or what are the problems with sarcoidosis? What did Dr. Nilanjan or Supreet see in routine, and what are the different cardiac sarcoidosis patients we have seen? We normally send for cardiac MRIs and other things specifically for a cardiac involvement. If it is an organ involvement, there might be a specific therapy. It's not steroid and disease modifying drugs might be required. We rarely see, and I happen to see these cardiac patients with this cardiac component more. How exactly, what are the common conduction problems, Dr. Nilanjan and Supreet, and Dr. Chandra Mouli can explain something which is really rare and about the cardiac MRIs.
Yeah. So sarcoidosis, we usually see blocks. We have seen few patients come with a heart block. So normally it is advised when you evaluate a patient with sarcoidosis, so ECG should be done at the baseline so as to identify. And if you suspect some problem in the ECG, I think we should go for a specific therapy. We have got cardiac MR to diagnose subclinical LV dysfunctions and all. But usually, what I have seen a few cases of sarcoidosis, they presented with heart block.
Okay. Okay. What are Nilanjan? What's your input in terms of cardiac and arrhythmias, sarcoidosis?
I think mostly I have seen patients who have gone into ventricular tachycardia, VTs. They have gone into VT, and it was a sarcoid patient. So after that, when they were later, they were evaluated. Once the VT was stabilized and the patient was stable, the patient had to be given shock and all. And once they were stabilized, and then they underwent a cardiac MRI, and then it was found that there was evidence of cardiac sarcoid. So yeah, I think that I've seen more of tachyarrhythmias. I have not seen many cases, hardly 2 or 3, but I've seen tachyarrhythmias.
Okay, so what exactly you have seen in terms of sarcoid, this thing, how exactly the management differs in cardiac involvement in sarcoids? Dr. Chandra Mouli?
So, this cardiac sarcoidosis, it can present in any way. Like it can have a bradyarrhythmia, it can have a tachyarrhythmia, and it can have a normal LV function or a decreased LV function. First of all, to diagnose nowadays we are seeing an isolated cardiac sarcoidosis without involvement of other organs also. So first of all, any patient with a new onset of LV dysfunction, we need to consider cardiac sarcoidosis as part of the DD and a cardiac MRI. On a cardiac MRI, based on the presentation of LG enhancement, late gadolinium enhancement, so we can make out whether it is a sarcoidosis or something else. The other things that comes into the diagnosis is chronic granulomatous inflammation, other granulomatous diseases. So, and in sarcoidosis, coming to bradyarrhythmias, it can be an AV block or it can be a bundle branch block. It can be RPPP or an LPPP. And tachyarrhythmias, as Dr. Nilanjan has mentioned, VT is more common. He can have VT episodes also, because there will be a scar formation in the area that is affected by the sarcoidosis. So that scar gives rise to a VT. So the treatment, coming to the treatment aspect, and other thing is LV dysfunction. The LVEF will be so much decreased, patient will be having heart failure also because of this sarcoidosis. So diagnosing sarcoid is important because it's one of the correctable causes for LV dysfunction. If you give steroids or a disease modifying drugs, we can as well correct the sarcoid. We can as well improve the EF also. So coming to the treatment part, particularly for sarcoid, steroids, disease modifying drugs, and coming to cardiology part, ICD, like we give an implantable defibrillator, cardioverter defibrillator, that is indicated.
See, there is a question from Dr. Amarjit Singh, Punjab, Batinda, how to treat arrhythmias in heart failure in reference. And I think that ICD, intravertebral and heart failures, I think those things are useful. Probably you can highlight Dr. Amarjit Singh's questions.
Yeah. So that is one scenario.
I think that is related to that.
Yeah, sarcoidosis patients have both heart failure and ventricular tachycardia also. So in such type of patient, rather than going for an ablation, we need to give an ICD. It is a class 1 indication because we can't ablate the entire LV in such patients. So giving an ICD will save the patient, life of the patient.
Can you just expand the ICD and for usefulness for people might
implantable cardioverter defibrillator. Okay. That is an ICD.
So it is put within the heart so that it will defibrillate if there is a arrhythmia. So I would rather tell one case scenario, Doctor. This thing, a young guy around 30-year-old is about to get married in a month or so, and he has this thing, and ultimately with the cardiac and pulmonary evaluation, there was a VT, it was recovered and all. But the problem issues comes, this arrhythmia settle means patient is absolutely fine. He doesn't look very sick and he wants to go. And there are a lot of issue with the cardiology and pulmonologist. The cardiologist says, you do DAMA, he can die and this thing and all. So that this becomes a very issue with the pulmonologist and cardiologist. So there was one patient who are behind us for 2 days. They were waiting and other things. I'm absolutely fine. Whatever happens, it's this thing. Then I went and asked personally, did a MDT. And I found then I discussed with the cardiologist and electrophysiologist and all. Is about to get this thing. We say that steroids will help, but if it happens again, who is responsible of that? So then he gave options. What are the options available? Then I was surprised. I didn't know that time that this existed. There is something called as a life jacket we can wear. We can wear that. That's what they said. I don't know that the life jacket the thing exists. So in sarcoidosis, so that you can get married and then come back after that. Can you just throw a light on those things?
So, that is wearable ACD. What we call it is a wearable ACD. Right now, it is out of market.
Okay, fine.
Right now, it is not available. So the options left for him are
intracardiac. Okay, fine.
And medical management. He should be on antiarrhythmics.
So there is no role of surgery in arrhythmias because recently also I will tell the case scenario that a patient came with syncope and they did a MRI and this thing and they are discharged him after doing a transthoracic echo and ECG was okay and she was okay and she came again with a syncope. Then they asked for a neurology, nothing is there. The cardiac, there was a VT, there was a recurrent VT and by the time we see it goes off. And this was recurrent in a young patients. I was really surprised and there was become a discussion in the hospital. And actually they went for a surgery and I suppose surgery I didn't know about. I heard about shock, pacemakers and other things. I heard about this ICD and all. And this surgery actually helped her. This thing, sympathectomy was done for these indications. So what are the role of surgeries in these arrhythmias?
Probably what the two surgical approaches I mentioned here, like probably thinking that the patient had VT star. Only in particular scenarios we go for surgery. Nowadays we do ablation for everything. Like any area of the heart we can approach and we can ablate that nidus. So surgery is the last option. And when it comes to sympathectomy, we don't consider it as a surgical procedure. We can do thoracoscopically also.
Okay.
So we can generally do a thoracoscopy and do a bilateral sympathectomy. And the other surgical thing that comes in the management of VT is an epicardial approach. If the patient has generally what we do is we ablate endocardially. We go inside the heart and ablate on the endocardium. But if the patient has something on the epicardium, then it becomes difficult. So we can't go inside and come outside. Then what we do is we enter the pericardium. In such scenarios, sometimes the surgeon's role come into place because they open the pericardium for us. We enter through that opening, go ablate the epicardium, map the epicardial surface of the heart and ablate it. So these are the only things right now, surgery in arrhythmic management.
It's amazing discussing with all you guys, and probably this arrhythmia has thrown a light on everything. And if you have to answer in 1 minute, what exactly want to conclude in terms of pulmonologists taking a message out, I would request Nilanjan, Supreet and Chandra to have one word. Maybe we will have a final word. Probably it's already late now. So Dr. Nilanjan.
Yeah. So what I would say is that we have to look beyond our pulmonology things. We have to look more at ECGs and try to interpret them, have a discussion with our cardiology friends, and so that we tend to identify. Unfortunately, we may not have somebody like Dr. Chandra with us, especially if we are on a night duty or people, our residents and all. So we cannot go for all this electrophysiological studies, or we don't have a esophageal echo. So yeah, definitely pulmonologists need to learn more about cardiology. And yeah, the right side of our heart is has to be managed exclusively by a pulmonologist. And the cardiologist can always add on. Always expert opinion should be well taken.
Okay, so Dr. Supreet.
Yeah. So regarding arrhythmias, I think we very well said. We should look at the ECGs, should properly interpret them and give medicines. And obviously, pulmonologist is better in doing a job on right side of the heart, because in my right side of the heart, pulmonary hypertension. I have got some patients of pulmonary heart failure. They don't not look up for radiology. But I said, the patient has got sleep apnea, hypoxia, that is leading to pulmonary hypertension. So cardiologist is more likely concerned with the left side, but definitely they are very helpful to us. And I think it's a team which helps in management of the patient. And definitely, when there's always look up to our cardiologist, and they always come up. So it's a teamwork, and we have to work complementary to each other.
Okay, Dr. Chandra, your last words to pulmonologists. They should refer all cases to you.
No. I don't expect, as a pulmonologist, I don't expect everyone to refer to me. See, my advice or my suggestion for any pulmonologist, whether the future coming pulmonologist is, be thorough with the ECG, because those are the problems I faced during my MD days or a critical day. Because MD general medicine people definitely will have an edge or the pulmonology, MD pulmonology people. So that should not be there, because pulmonologists are half cardiologists. They treat the right side, as you rightly said. No, they treat with the right side of the heart. So that's why they need to know ECG, at least not everything regarding the ECG, but at least they need to know what is happening in the ECG. At least they should know which patients to refer, rather than referring everyone.
Thank you very much, Dr. Nilanjan, Dr. Supreet, and Dr. Chandra for your wonderful interactions. I feel heart is in the safe hands of both lungs, and whenever we look at, we don't have to go into too much vectors and other things. We just have to see whether there is a tachycardia or a bradycardia. If you see something T is missing, that is good enough, or something is missing, there is always people to hand-holding in the hospital. There might be people who are interested when you really look at, and now it's WhatsApp and all. We can just get this into the act. Some rare cases need specific treatment. We should be aware of that. And thank you all for making it interesting. And thank you one and all. Thank you very much.
Thank you,
everyone.
Thank you.
Thank you, everyone. Yeah.